Bismillahirrahmanirrahim. Hi everyone. So today we're going to talk about the first of the ACGME 6 core competencies, which is patient care. A lot of people say that this is probably the most important one. I kind of agree, but I also personally feel like professionalism is also as equal as important, and professionalism probably encompasses all the other competencies. But anyways, I mean, patient care is really crucial, and probably that's might be the main reason that many of us really went to medical school to be able to be good physicians who can provide excellent patient care. So let's talk about the this core competency and the sub-competencies associated with it. So as you can expect, the first sub-competency is history taking. Basically, the resident are expected to go from level 1, being able to take history for common and simple cases, to levels 4 and 5 by the time of their graduation, and hopefully they'll be able to take even more complex histories for less common and more complex cases. So as you know, history is really crucial. It's about 70-80% of the diagnosis. There's a lot we can say about history skills, but I really believe it's an art. It needs practice. You have to pay attention really to it. It's a really important component of patient encounter, and it's not really just simply like question and answer, but it's really the art of being a good listener and being able to articulate well with the patient and try to get the patient story in the right way. And some of the advice that I usually give and usually mention in the literature is always try to listen carefully to your patient and start with open-ended questions rather than lead questions. But lead questions are useful as well. And then also again try to get the whole picture of what's going on with the patient after the background, the medical background of your patient. And also always remember to try to get the history from different resources, not just the patient, but also the family, sometimes even friends, nursing home staff if the patient from nursing home, the primary care doctor, if the patient had a well-established relationship with a primary care physician. Also look into all the previous record for the electronic health system that you have in your hospital, but be aware of the chart rumors, stuff that might be listed in the chart, but it's not necessarily true. Also, one advice I usually give to my residents, especially in the inpatient setting, when they're being asked to admit a patient and they already have a lot of data available for them. So sometimes they might be biased by these data before they go and take the history from the patient. So I actually, funny enough, I was talking to my resident early this morning about that. We talked about a patient who came in with chest pain. Initial evaluation suggested that the patient might need left heart cath in the emergency department, but careful history actually suggested that it's probably not ischemic chest pain, and we thought about other differential diagnoses, including pericarditis, and patient ended up actually having pericardial effusion and pericarditis, and the left heart cath was canceled, and the patient get insane and was treated as pericarditis. So again, it can be tricky, but I think it's really crucial that the young physicians pay a lot of attention to the history, even if you're inheriting a patient from your colleague or coming to the shift or to the rotation, and the patient is already established with a diagnosis. Take a few minutes and take a really brief history from the patient, especially if you have a clear diagnosis, and see what's the patient story that really correlates with the final diagnosis that you have on hand. That can be really helpful, so that for in the future, if you have a similar case, then you might remember the diagnosis and be able to make the diagnosis easier. As you might have expected, the second sub-competency is physical examination. So hopefully your resident will be able to move from level 1, being able to be able to elicit simple findings for common pathologies, to level 4 and 5, where their physical exam can really elicit subtle physical exam findings and for complex pathologies, and hopefully be able to teach interns and medical students appropriate physical examination. I have a separate video about that. A lot we can talk about physical exam and the concern about skills of physicians being less refined than before, and the deterioration of physical examination skills because of the availability now of diagnostic tests and all that. So I'm not going to go into details. You can go to the video about that, and actually one of the most viewed videos in my series. So, and just to kind of briefly summarize some of the advice that I had, pay a lot of attention to physical exam when you're during your first encounter with the patient, when you're seeing the patient for the first time. Not just if the patient is being admitted, but also if you are inheriting the patient from someone else and you're seeing the patient for the first time for any reason. And then observation is really key. Be a good observer, look around, look at the chest before you examine it, look at the abdomen before you examine it, look at the hands, don't forget to look at the skin. And, I really had a lot of stories about how subtle, really simple, observable physical exam findings have been missed before. And also, in that video, I talked about evidence-based physical examination and the importance of the physician to be aware of the usefulness of the physical exam. Not all the maneuver that you learn during medical school are necessary, and important. So some of them are really not very useful at all. So consult literature, look into what's available for you in terms of the usefulness of physical examination findings, and try to adopt these findings and have a systematic way of doing your own physical examination. The third sub-competency that we need to pay a little bit more attention to is clinical reasoning. It's really a very complex process, and clinical reasoning basically is really kind of the mental process that includes interpretation of the data and coming up with a differential diagnosis, and basically the process behind clinical decision making. So hopefully the resident will be able to come up with simple differential diagnosis at the beginning of their training, and be able to integrate the simple data that he or she gathered, and moving to the level 4 or 5, when they're able to come up with more detailed, more complex differential diagnosis, and be able to interpret more detailed data and come up with a little bit more organized and detailed management plan. I have really special interest in clinical reasoning, so hopefully I'll be able to make some videos to talk about that, and about type 1 and type 2 thinking, and all the mental process that goes with the clinical reasoning. But basically, an important part of the clinical reasoning is, of course, medical knowledge, which is a separate core competency as well. But it's really not just about reading more. It's also about how you organize the medical knowledge that you had, and how you connect dots together, and how you read, and from where you read, and when do you read, and all that. So it's a little bit more complex process, and also experience is really important. And that's why I always encourage my residents to, if they're asked to see more patients, actually there's a lot of benefit for that, so they can really look at the full half of the class when they feel like they're really busy and seeing a lot of patients. Of course, if you're seeing an overwhelming number of patients, that's not good. But overall, the more experience that you get is by the more you feel comfortable with your decisions, and basically you gain that. One of the ways that you can master this skill is by seeing more patients in an appropriate setting. And then other suggestions is to have what people call diagnostic timeout, is to, especially with complex cases, to pause a little bit and ask yourself, what else could it be? Maybe broaden the differential a little bit more. Ask yourself why this is what happened, why this patient is having CSS exacerbation, if it's compliance issue, why the patient is non-compliant, and what does not fit. if there is a lab result that doesn't really fit the clinical picture, then you ask yourself why this lab is in this range. Or if you see an incidental finding in imaging, try to think, is this linked to the patient history and story, or is this an incidental finding, and so on and so forth. So there's a lot of suggestion how you can improve your clinical reasoning. So again, hopefully we'll be able to make a separate video about that skill as well. The fourth sub-competency here is really straightforward, which is the patient management. Again, hopefully the resident will be able to move from level 1, being able to execute simple assessment and plan for simple cases, to level 4 or 5, where he or she can execute complex assessment and plan for complicated and complex cases. So basically, this is really the way that the resident is managing the patient in the inpatient setting or the outpatient setting or with subspecialties. So some general advice I will give is, always try to come up with your own plan. So once you see the patient and you gather the data, you look into the chart, you talk to the family, you look into the labs. Before rounding, always try to have your own plan, and then present this plan and the clinical reasoning behind that plan to the attending, and then see what the attending will say. Then they might or might not agree with you, and when they disagree, they might give you their clinical reason why they think there might be a better plan. But whenever they feel like you make the effort to come up with your own plan, that really gives you a lot of advantages. First, it tells the attending that you're really making an effort to learn, and also it really gives the attending the opportunity to correct you and give you the right, or what he or she thinks is the right plan based on his or her experience. So if I don't know what's in your mind, I really cannot rectify it in the appropriate way. So remember, always try to come up with your own plan. When you calling the attending with an update, for example, always try to tell the attending what you think should be done with this acute issue that comes up, or with this new data that you are presenting to him or her. And then also it entails getting things done for your patient. This is basically efficiency. So the attending would like all his or her resident to be able to do the plan as it was formulated during rounds, so that when they come next day, everything is set up, everything is done, the plan is initiated. That's really important. That's really an important part of the assessment. And then reducing unnecessary testing and medications. That's really key. I think a lot of times you really have to review your plan every day and make sure that any medications that is not needed, is taken out. If the patient pain is getting better, the patient doesn't need to be in IV pain medication anymore. If the patient is the diagnosis now is clear, there might be no need to order the echo or the CT scan or the MRI that was initially planned. So always review your management plan, and make sure that any unnecessary testing is not ordered. The classic example also being the daily labs. Not every single patient in the inpatient setting needs daily lab, and this is really a very common problem, especially if the patient is really pending social work and case management consultation for safe discharge planning. This patient might not need the CBC and the CMB that we usually order every day. So be mindful about that as well. And fifth sub-competency here is under patient care is digital health, which is basically the use of the electronic health record. Resident expected to move from level 1, being able to use the electronic health record routinely for day-to-day basis, and from this level moving to the second, third, and then hopefully by the time of graduation to the fourth and fifth level, where they can use the details to achieve target qualities and improve patient care, and even do some quality improvement and advance, patient safety and all that. So some of the advice that I will give is really to pay attention to your daily notes, your admission note, your discharge note, your progress note. And actually, I had a video about what to look for in a good resident note. Hopefully, we'll be able to see that video. And there, I talked about giving some tips and importance of writing good progress notes. Remember, a lengthy note doesn't mean it's good. Actually, if it's short and informative, that's much better. Avoid redundancy and make sure that you tell the reader about the thought process and the clinical reasoning, again, behind your plan in your note. And then also make sure that you sign your notes on timely fashion and update it regularly. Remember that your note, this is where all the people who are taking care of your patient, they look at. The nurses, they look at your note. The subspecialists, when they come to see your patient, they look at your note. And, it's really, it's just hugely important. And again, I highly encourage you to look at the video that we talked about, writing good notes. And then be curious and explore. I mean, honestly, a lot of these digital health, despite some of the limitations and pitfalls associated with it, and complaints that many healthcare providers complain about them, there's still really a lot of usefulness to them. And some of these digital health, actually, they really have very nice features. For example, I remember that in Epic, you can actually, they have a panel for example, just pain, the data that you need to manage pain, the data that you need to manage anticoagulation, including the INR, PT, and medication that were given, the data that you need to manage antibiotics, including the initiation date and the dose and the duration and medications, antibiotic level, and all that. So take advantage of this. Ask the IT people; they're very helpful. If you have a question about how to use the electronic health record in a certain way, ask them. They might give you some tips how to improve your usage of the digital health. It's really there's a lot of features, I would say, that we're really not using that much. You don't have to be tech savvy to really take advantage of it, but just be curious, ask around, ask your seniors, ask those who really have some more experience, IT people and all that, and then you hopefully be able to come up with really a very efficient way of using the digital health in the benefit of your patient and your own benefit also, to make your presentations and to make your patient care really efficient and get high scores in the evaluations. Now, talking about all this sub-competencies, the main question maybe is, what would be the best way that the programs can really evaluate the resident for the patient care? I mean, this is really very complicated, and of course, there's no one single perfect method that all the programs should use. It really varies a lot, but generally the ACGME has some suggestions for the programs, and I think the resident need to be aware of it. Actually, you might actually suggest some of these methods to your program if you feel like it's a good method to reflect this competency in the really nice way to the program, so that it will be fair to the resident, so that they will be evaluated in a very fair way. So, for example, direct observation, for example, what I do on daily basis when I go and see the patient at the bedside and ask the resident to talk to the patient about the plan. Sometimes I watch them do some physical exam maneuvers, So this is simple direct observation method. You can do some rating scales or evaluation forms. Some programs might ask some of the residents to go and see the patient, and they have a list of the things that they check, and then they give the resident the feedback about what they missed and what they did well and what they did and where they need to improve. And also audits. A lot of programs do some audits. For example, in the outpatient setting, they look into the notes for patients with diabetes and see what quality measures has been done or has not been done, and they can give you feedback about that. This part of the patient care. and simulation also, especially when it comes to procedures, or also like for example simulating a difficult patient. It's definitely one thing that some programs still use. Again, it doesn't have to be procedures only, but you can do simulation for physical exam also as well. A lot of things that you can use this method for. And then of course case logs and registers, and re-examining the resident notes and evaluations and all that. This is all part of the method that some programs can use to evaluate your the resident performance. Finally, this is an example of an app that the ACGME has launched. I haven't used this app myself, or I haven't worked in a program that uses this app, but I think it's it's something to consider, and it would be interesting if anyone in any other program who have used this app is to really let us know what they think about it and whether it was useful or not. It's called the ACGME's Direct Observation of Clinical Care app, or so basically it might help the resident and faculty evaluate the learners' history and physical examination skills, clinical reasoning, and informed decision making. This is the part that's related to patient care, and of course including breaking bad news as well. So if you use it, let us know, is it really useful or not. But again, be creative, think outside of the box, try to come up with some method that you think it's going to be very useful to kind of make sure that the residents are being really evaluated in the appropriate way, and don't hesitate to suggest that to your program, and try it and see what happens, and hopefully you get a good outcome with them.